Hi, everyone. Thank you. I have actually never been to St. Louis, and so when I flew in, I think I was hoping to maybe catch a glimpse of the arch, and I don't think I realized that the arch is just right there, gigantic. So this is such a treat. Let's see. Great. So this is the agenda of my talk today. I want to do two pieces. I want to share where liquid biopsy is today using Guardant assays as part of the example, and then lean into how that adds to comprehensive genomic profiling alongside tissue biopsy. I'm going to be focusing most of my talk with advanced stage cancers today. And then from there, I want to move into what we are planning on doing and what we want to do towards the future, which is using our Guardant Infinity assay and also using methylation to uncover cancer signatures. What I hope that you all take today is either maybe a deeper understanding of a liquid biopsy and or maybe some interesting brainstorming around where we should be using this technology moving forward. So shown here is a snapshot of our current clinical assays. Most of these are liquid biopsy tools that are diagnostic and cross the continuum of cancer care. Starting from the left, we have our Shield assay. This was FDA approved as of a week ago for a screening assay for colorectal cancer. Moving along towards the middle, we have recurrence monitoring for early stage cancer and cancer with curative intent treatment. This assay, Guardant Reveal, uses methylation only to detect minimal residual disease. And then moving further towards the right, we have in our advanced stage setting multiple assays, including our flagship assays, Guardant 360 CDX and Guardant 360, which are used to identify actionable biomarkers to make informative treatment decision-making in advanced stage solid tumors. We also have a liquid biopsy assay called Guardant 360 Response, which is a molecular response assay. And then finally, we have a single tissue biopsy test called Guardant 360 TissueNext. So I just want to start with what is ctDNA. ctDNA is short for circulating tumor DNA. This is free-floating DNA that is expressed from the cancer cells and is typically released as the cancer cells are undergoing cell death, either through apoptosis or necrosis. So essentially, the more that those tumor cells are growing and dividing in time, that rapid turnover is going to lead to release of ctDNA that we can then pick up through a peripheral blood draw. What I think is interesting is that cell-free DNA is a biological phenomenon that is quite natural, so we are just utilizing that in order to get an easy picture of what the tumor genomics look like at a single point in time. When we think about liquid biopsy, especially in the advanced stage setting, we think about sequencing the tumor, and the historic precedent has been to use tissue biopsy in order to identify what these genomics are. There are some unique liquid biopsy features that make it a helpful addition to comprehensive genomic profiling alongside tissue biopsy. So, for example, especially relative to a tissue biopsy, a liquid biopsy is going to be minimally invasive in that, especially for our test, we can just use a blood draw to capture the ctDNA and then run next generation sequencing versus a tissue biopsy that can be more invasive or harder to get. Another feature is that liquid biopsies tend to have a faster turnaround time. This is because they require less processing and the QNS rates are much lower. So in the table on the right, what you are seeing are two clinical trials for Nile and PopPat, and this is a comparison of median turnaround time between Guardant 360 and the respective tissue genotyping used. So in these two trials, we're seeing a median turnaround time for Guardant 360 of 9 and 8 days versus 15 and 22 days for tissue testing. And I will say that on our current commercial assays, the turnaround times are much closer to 7 to 11 days, depending on which assay you order. The other unique feature about liquid biopsy is that it's able to overcome some of the heterogeneity limitations of tissue biopsy assays. This includes both spatial heterogeneity and temporal heterogeneity. Spatial heterogeneity refers to both inter-tumor heterogeneity, wherein the genetics may be different between lesions of the body. So if you think about different metastatic sites, there may be distinct genomics. It can also refer to intra-tumor heterogeneity, where if you're looking within a tumor, there may be distinct subclones, and depending on where you're taking your biopsy, you may be getting unique genetics. We have a provider who uses the analogy of, say, like a pizza. And if you took a biopsy at one side of the pizza, maybe you'd get a pepperoni, maybe you'd get some cheese, maybe you'd get a mushroom. And so the nice thing about liquid biopsy is that wherever ctDNA is being shed in the body, we will be able to harvest that and sequence it to get a picture about what's driving the tumor. The other heterogeneity is temporal heterogeneity. Temporal refers to time. And specifically, this is how the cancer genetics are going to change over time, and specifically over lines of therapy as the cancer becomes resistant to each line of therapy. So in this model, you're seeing how the subclone colors change over between first line to second line. We see more yellow subclones between second and third line. We see more of these pink subclones emerge. And this can be useful, especially in the advanced stage setting, in order to identify mechanisms of resistance and potential new drivers that can be targeted. One piece of liquid biopsy is that ctDNA detection can be affected by tumor shed. And so because of this, it's important to understand when to do this testing. So what you're seeing on the graph on the left are the frequencies of somatic alterations detected across a range of cancer types from around 22,000 patients. The little bar on the far right is a glioblastoma, and you can see that it's quite low compared to some of the other tumors on there, like, say, non-small cell lung cancer. And this is because certain biological differences can limit the amount of ctDNA shed. So, for example, in that case, glioblastoma, some of that ctDNA is blocked by the blood-brain barrier. We also know that this affects when we should do ctDNA testing to ensure that we get the most amount of material to support sequencing. So most of our providers in the advanced stage setting are using this test either at diagnosis or at progression, when we would expect the tumor to be the most active and to be releasing the most ctDNA. On top of that, we are also using this technology as a way to look at tumor burden, in that we are also expecting tumor fraction to change according to how the cancer is progressing or not progressing. And so ultimately, when we talk about liquid biopsies, we talk about them working alongside tissue biopsies, and that because of these distinct biologies, using both of these assays together is going to allow for the highest capture of genetic alterations to inform treatment decision-making. Alongside that, again, liquid biopsy does tend to have a faster turnaround time, so when we look at these different paradigms, running both assays and running liquid either first or simultaneously will give you the highest capture rate with the fastest turnaround time. So leaning that into our conversation around comprehensive genomic profiling, I'm going to feature the Guardant 360 assays. I know there are a number of assays that we can talk about, but just for the sake of time, I'm just going to focus here. So once again, Guardant 360 and Guardant 360 CDX are assays in the advanced stage solid tumor space that are used to identify genetic alterations that can inform treatment decision-making. When we think about advanced stage cancer care, typically the patient goes through diagnosis, then they are given genomic profiling, which is going to inform their treatment planning. From there, they tend to be given one of three treatment classes, either chemotherapy, targeted therapy, or immunotherapy. And what we know from the literature is that patients who have tumors driven by certain drivers should be on their matched FDA-approved targeted therapy. Here's some data helping to support this. This is in metastatic non-small cell lung cancer patients. What you're seeing on the graph on the left is a Kaplan-Meier curve of overall survival, and there's two groups being represented in blue. These are patients who were treated after their testing was completed and the provider had the results in hand, versus the patients in the red who were treated before they had those results back. So you can imagine the results not coming back, the physician needs to make a decision, let's just put the patient on chemo IO. But what we see is that the overall survival is distinct between these patient groups. And what the paper mentioned is that a big chunk of the patients in that available testing group, that blue group, did have liquid and tissue biopsies reported. The reason this is so important is that patients may only get one chance at therapy. Around 40 to 60% of metastatic non-small cell lung cancer patients never receive a second-line treatment. So it does seem important to be able to have all the information at hand prior to making these treatment decisions. And I know that I'm talking a lot about non-small cell lung cancer. This is just where a lot of our data is, but do want to share that there are many informative biomarkers across cancer types: breast, colorectal, prostate, gastric, melanoma, et cetera, and even quite a few pan-cancer tissue-agnostic markers to look for. When you're using a somatic next-generation sequencing test, it's important to know that cell-free DNA is quantifiable, but these alterations are typically identified at very low VAFs. What you're seeing is a graph from that same paper looking at what the variant allele frequency typically is for some of these somatic alterations that we detect. The median is at 0.41%, so that's quite low, indicating that you need a pretty sensitive assay in order to identify these targets. Just want to share that we do have quite a bit of data showcasing that Guardant 360 is comparable sensitivity to comprehensive tissue, and that there's high concordance for targetable driver mutations in this paper specifically for non-small cell lung cancer. Sometimes we get physicians who run the test, they see a driver alteration come back, and it's at a very low VAF, and the question is, can I still treat this? And what I want to share is that these assays are designed with specificity in mind. And so one thing is we have data showcasing that there are patients who have very low VAFs and these driver alterations who were treated and still had good response. So the two patients listed here, patient 14 had an EGFR L833V mutation at 0.79% VAF, who achieved a partial response on osimertinib. Patient 17 had an EML4 ALK fusion at 0.05% VAF, very low. And they also achieved a partial response on crizotinib. So the messaging tends to be, if you see it, you can treat it. I just want to conclude this section by showcasing that our Guardant 360 assays are very well informed, a high number of publications. We hit a nice milestone of 500 plus publications by ASCO, a high number of patients tested, and good coverage and fast turnaround time. Okay, now I want to change gears. This was the current. Now we're moving into the future. Where do we hope to go and take this data? Which is what it says on this slide. So the assay that I want to talk to you about is a platform called Guardant Infinity. This is taking quite a bit of the technology that we use to develop Guardant 360, that genomic profiling, and adding on a component with epigenomics. The reason being that genomics isn't telling the whole story. And when we think about genomics and sequencing the data, the DNA data, we're not seeing exactly what's driving that tumor. But what the literature tells us is that the epigenomics, which are influencing that rate of DNA expression, are, there's a lot of information there for what we're seeing with the tumor etiology as well as tumorigenesis. What you're seeing here is the core module for our Guardant Infinity research use only assay. This would be, so if you have any plasma samples in the freezer right now, I'd love for you to start thinking about them. But for Guardant Infinity on the research use only panel, we're able to run our genomic panel on over 800 genes on a 4 megabase backbone. And then for methylation, we have a 15 megabase methylome that we can explore. Some of the reporting is going to be what you're used to: genotyping, TMB, MSI high, genomic rearrangements, copy number loss. But then we also have some methylation-informed pieces, and of course we want to develop even more. So things like tumor fraction score, which I'll talk about in a minute, molecular response, and then additional pieces like hypermethylation, et cetera. In this slide, what I want to show you are some of the modules that we are interested in building, but of course this is just a small example. So things like using methylation information to inform IO modules, which patients are going to do well on immunotherapy versus not, an HRD module, which patients are going to do well on PARP inhibitors and platinums versus not, and even a viral module, which we can use to inform decision-making in, say, head and neck and gastric cancer. So if you have samples if you have plasma samples in the freezer that you're thinking of, these are some of the collaboration opportunities that we are thinking through, and I'd love to talk to you a little bit more after this. things like validation of new biomarkers, novel discoveries, novel signatures. There's a lot that we can do here. And I'm going to change gears a little bit and talk to you about one of our methylation-informed signatures that we have a little bit of data on. So this is tumor fraction. Tumor fraction is used as a proxy of disease burden. And similar to what I was describing earlier, we're using that same biology where we are expecting there to be less ctDNA shed as a tumor is responding to treatment versus when it's progressing. There's a number of ways to do tumor fraction. Historically, most of the data has been in genomics, but there are some challenges to using genomic-only assays. Things like aneuploidy and germline alterations are going to obfuscate what the signal is. So we are leaning into methylation as a way to bypass some of those factors and have a more refined value to help inform how the patient is progressing or not progressing over time. So shown in this image is a schematic of how we run our methylation signal. From a blood draw, we have a proprietary method to barcode the methylated ctDNA fragments. And then when we compare them as a denominator to total cfDNA, that gives us a quantitative value that we can look at over serial testing. In order to develop this, we had to evaluate thousands of differentially methylated regions to really identify which of these are coming from the tumor versus not. So these are DMRs. You can think about them as patterns of methylation. And so we took normal populations of people and explored their methylome and even included those with quite a few comorbidities and compared them to those with cancer in order to identify what are these DMRs that are going to be very informative. Shown in this image is from a publication in metastatic breast cancer patients where we were able to apply this methylation-based tumor fraction. Shown on the left is what I just described. We're comparing a normal population of people to those with tumor DNA in order to identify those DMRs. In the middle, this is how we quantify that tumor fraction score. We take an average of some of those top DMRs and compare it to positive control regions, and that gives us a score. And on the far right, you're seeing a figure comparing methylation-based tumor fraction to the genomic max-MAF of those samples. We would expect there to be a high correlation, and that is what we tend to see. So methylation-based tumor fraction does seem to correlate with the genomic max-MAF. Moving forward in this paper, which a population of metastatic breast cancer patients, we also followed how those methylation-based tumor fraction scores associated with tumor volume over time. So what you're seeing on the left are just two example images of imaging for these patients. And on the right, these are 5 separate patients with serial time points. And in red, you're comparing the radiologic assessment of tumor volume. And in black, you're comparing the methylation-based tumor fraction. And what you should see pretty clearly is that these seem to mirror each other. So as tumor fraction goes up, some of these tumor volumes go up, and vice versa. So we do see some good analytical and clinical validation that methylation-based tumor fraction is reflecting the tumor volume. Moreover, we have an abstract presented at AACR. This is also breast cancer, specifically HR-positive, HER2-negative metastatic breast cancer treated with CDK4/6 inhibitors. What you're seeing in the graphs, these are both survival curves. The top one is for time to treatment discontinuation. The bottom one is for overall survival. And we're comparing 3 groups. So in green, these are patients who at baseline, their methylation tumor fraction was not detected. You can see that they have the best outcomes, particularly for overall survival. Then we stratified patients with methylation tumor fraction detected at baseline as those that are either less than or equal to median in blue or greater than the median in red. And so what you see is that patients who had methylation tumor fraction greater than the median tended to do the worst. So a question that is going to come up is what do I do with these numbers? What do each of these numbers mean? And I think where we're at with the data right now is that there does seem to be a prognostic signature, and then we need to do more work to really get granular on what are those numbers that should influence next treatment steps. And it seems like these are going to be distinct for cancer type and by treatment class. So would love the collaboration of the people in this room for how we can move forward there. We had a big update for our Guardant 360 assay. This is, we have 2 panels. This is the larger panel. So about 2 weeks ago, this Guardant 360 assay moved onto that Infinity platform. It now reports on over 739 genes. I know you can't read those, I'm sorry. I'm happy to send it to you afterwards or direct you to that link so that you can see if your pet gene is on there, but a much broader genomic picture. And then on top of this, we are now also offering methylation tumor fraction on these reports as well. So we are hoping that as these report out clinically, we'll be able to develop more of that hypothesis generating data for how to move forward. And then in the last chunk of this presentation, I'd like to share with you some of the early signatures that we have in methylation that are informing some of these unique cancer signatures. Quick plug that at the poster session, we have 4 posters. I'm just going to be chatting briefly about one of them today, but would love to meet you guys tomorrow to chat more. I'd like to describe a methylation-informed histology classifier. So this is specific for non-small cell lung cancer. Non-small cell lung cancer comes in different subtypes. In pink is adenocarcinoma. This is the majority of our cases. In blue is squamous cell carcinoma, 20 to 30% of cases. And then in 10 to 20% of cases, you'd expect to see some large cell carcinoma and other subtypes. So we developed this collar to better identify between adenocarcinoma and squamous cell carcinoma. The way that we built that is that we took methylation data from the TCGA to train a model in order to identify between these 2 subtypes. What you're seeing on the curve on the left, this is a receiver operating curve. It describes how the sensitivity responds to different thresholds of specificity as they increase over time. A good collar would be one where the curve is as far left as possible and as high up to the top as possible, giving you an area under the curve of 1. So we used TCGA data, machine learning, built a model. We applied it to TCGA data, and we were able to see that that area under the curve is 0.97. So good analytical validation that it works, and we see good separation between those tumor types. Then we took that model, and we applied it on our Infinity data. So we have 2 sets of data here. On the far left, this is Infinity data where the tumor fraction was greater than or equal to 1%. We see that the area under the curve is 0.94, so still pretty good separation. And we also looked at tumor fraction where the tumor fraction was greater than or equal to 0.05%. And when we look at a population with a lower tumor fraction, the area under the curve is 0.89, which is still pretty good, but we do see some separation as tumor fraction decreases. So I could probably hear you thinking, you know, I don't know that I need liquid biopsy to differentiate between squamous cell carcinoma today, but I'd love to just think broadly where we could take this information. Our histology classification doesn't have to stop here. So as you think through your cancer types, things like a small cell collar, things like in breast, different cancer types, there's a lot of opportunities here to develop more signatures that would be useful in the clinic. And with all that in mind, the posters that we do have for today, we have one looking at whole genome duplication. We have one looking at BRCA1 promoter methylation. There's a lot of opportunity to explore these hyperpromoter methylations that are gene specific. We have the histology classifier that I just described. And on the bottom far right, again, I know you can't read it, but this is a collar to identify patients who are likely to have cardiac adverse events while on Herceptin. So there's a lot of power here, and we are in the early stages of it, but would love to chat with you all more if you have more ideas for where we should go. And so ending with almost 5 minutes to spare, crushed it. Just want to throw in a plug that would love to talk to you more. My email's listed here, some business cards at our table. And if you had questions on this presentation, for any clinical folks, if you had questions around when to use these assays, research collaboration opportunities, again, think through those dusty, frozen samples in your freezer. Would love to hear about those. Or even just any feedback on where you think ctDNA and some of these methylation-informed signatures could be valuable for your patients. And with that, I'm happy to take any questions.
Very excited about the data and especially interested in the methylation-based tumor fraction assay that's coming out. So just going back to your breast cancer data, I wonder the prospect that it actually associates with prognostication of disease progression. It's really exciting and useful. I hope it's useful. And so I just wonder, going back to the fundamentals of the performance characteristics of your assay for that, you didn't talk anything about the assay's limit of detection and sensitivity to the aspect of limit of detection, really how much tumor it's gonna be able to actually predict progression. Yeah.
Yes, I think that's a great question. What we do know is the limit of quantification. I believe that number is about 0.3%, and that's different from our limit of detection for that clinical assay, which is about 0.01%. I'd love to double check those numbers at my booth. But towards your point, how those reflect prognostics currently, I think we're just still a little early, and that's some of the data that we're starting to develop.
I see, great. Well, then did you do all these only in the solid tumors, or are they also applicable in hematologic malignancies?
Currently only solid tumors.
Okay, thank you.
Thank you. Okay. Oh, one more.
Fantastic work for the AUC. Even for 1%, it's very, very interesting, very, very surprising and significant. And do you have any further work on the CNS tumor or other tumor type?
No, we haven't done much with CNS tumors, and I think it is always going to be a little bit challenging with the biological limitations of those. But I suppose I should ask, would this be useful with CNS tumors?
So you seem to compare with the German groups, the results.
Oh, okay. Thank you.